called in SWAT?
Just a precaution. They still haven't found the shooter yet.
They need to stay out there, not in here.
Officer down. You know the drill.
16 gauge in the right AC.
Definitely needs an airway.
Handle that bleeding.
Need a sponge stick for the back.
And 100 ketamine and get some 4x4s on the...
The patient here needs intubation as the bullet wound has traversed through one side of the face. Ketamine is a dissociative general anesthetic agent, likely used here for procedural sedation for intubation. Kelly is a type of hemostat or clamp used here to control bleeding with gauze.
You guys are doing a great job. Keep it up. You know, Ricky, you're in good hands. You'll be okay, man.
Hey, guys, back it up. We're trying to work here. Come on. Both of you, go.
And chest tube output is minimal. Good for cardiothoracic ICU.
Nice. Okay, as soon as transfer can lend us a hand.
If the chest tube output was rapid and not slowing down, filling up the chest drain up to 1.5 liters, the patient would need a thoracotomy to surgically repair the bleeding site after identifying the bleeder.
What's up with the SWAT team?
Maybe they think the shooter's coming here?
Shit, is that true? What? My kid's in the break room.
They think the shooter's heading this way.
Anything is possible.
Don't spread rumors. I'm taking this one to the OR.
It's a nightmare situation to be in. Don't know how you could think straight and just do your work when there's imminent threat to your own life. Most of us in real life would just freeze at the thought of it.
How are you doing?
Yeah, I'm good. You?
I'm good. How much blood are we getting?
I don't know. Hope it's enough.
We're supposed to stop here and stay between 10 o'clock and 2 o'clock.
Where's 12?
I think the pilot's 12. I think we just stay back and they bring the blood to us.
Thank you.
Yep.
These are uncross-matched O positive and O negative blood that comes in handy in emergency situations like this. O negative PRBCs is the universal donor for all patients, and it's used especially for females of childbearing potential to avoid Rh sensitization and avoid hemolytic disease of newborn in future pregnancy. O positive PRBCs is the universal donor for most adult males and postmenopausal females because it preserves the limited O negative stock and the Rh incompatibility risk is low.
Do we take these to our supplier in behavioral health?
Trauma rooms first, then we'll make our way out to the patients in the hub.
That the O-neg delivered?
Yeah, straight from the roof.
Jesse, hang the unit, then right up to the OR. Who else needs blood?
Everybody.
Most patients from gunshot wound injuries either have hemothorax or bleeding from the limbs or head, and so essentially everybody requires blood transfusion. Massive transfusion refers to 4 or more units of PRBCs transfused in 1 hour with ongoing need or replacement of more than 50% of total blood volume within 3 hours. For a case of trauma, massive transfusion is usually indicated in penetrating or blunt trauma with hemodynamic instability, unresponsive to initial fluids, including massive intra-abdominal, pelvic, or thoracic bleeding. Examples would include ruptured spleen, liver laceration, or pelvic fracture or vascular injury with uncontrolled hemorrhage.
Leave us 4 units, 4 next door, and then check in with Robbie and Abbott. Okay, I've got next door.
The blood's here.
Wait, squeeze my hands as fast as you can.
Back for me.
You guys need blood?
No, not just yet. Leave it with Dana. Hey, Whitaker, how you doing?
Yeah, fine.
Ask for help if you need it.
I can't see the cords. Let's bag him. Sorry, I'm used to the glide scope.
Spoiled by technology.
That's true. We're so used to the video laryngoscope with a camera attached at the end of the blade that provides indirect visualization of the cords on the screen. And when it's time to use the normal direct laryngoscope where you gotta manipulate it to have a direct line of sight of the vocal cords, we fail. So it's always prudent to start practicing first with the normal one before moving to the convenient video assisted one. The direct laryngoscope comes in handy in mass casualties like this where we can't afford using the video ones.
Dana, you got a bougie back there?
Since the intubation is difficult here, he wants to use the scalpel finger bougie cricothyrotomy technique as in the previous episode. Basically make a horizontal incision through the skin and cricothyroid membrane, insert finger to dilate the passage, and insert a bougie into the trachea through the opening, then railroad the endotracheal tube over it.
Completely out. Use them all up.
Is he awake?
He was. Now he's sedated.
Should be intubated by now.
Yeah, what's his pulse ox?
All right, except for his partner, all of you. Into PH2 now. You can watch from the window, but you need to zip it, capiche?
Since bougie isn't available, he's still trying the intubation with the direct line of sight. It's difficult to concentrate and perform a difficult procedure if the onlookers are constantly nagging about things not happening in time. So it's better to have no onlookers nowhere near the procedure area, at least.
Oh, God. Bridget, thank God. Night shift to the rescue.
What the hell happened to your eye?
Just another happy customer. Looks a lot worse than it is.
Yeah, right.
Eye injuries do look worse than it is due to the periorbital hematoma. Basically, direct blow to the eye or surrounding area ruptures small blood vessels in eyelids and periorbital tissues. Even in indirect injury like blow to the forehead or scalp or basilar skull fracture, the blood tracks down via gravity into the loose eyelid tissue. The skin in the eyelids is thin and the underlying subcutaneous tissue is loose, hence blood can track down here and accumulate rapidly. Hence, even minor injuries can lead to significant swelling and discoloration within hours. Initially, the discoloration is reddish purple, then hemoglobin breaks down into biliverdin, bilirubin, and hemosiderin, which cause blue-green-yellow color changes, making it look even worse even after swelling subsides.
I tried to get here sooner, but it is gridlocked out there.
It's not much better in here. Did you hear anything about the shooter?
They may have slipped away in the crowd with all this chaos. Hey, where do you need me?
North is yellow. Keep an eye on the new kids.
Got it. You holler if you're in trouble.
Yes, ma'am.
Jamie, what do you need?
IVs on everyone?
Hi, I'm Dr. King.
Buster Pirelli.
I take it you're a children's entertainer?
Impressive observational skills.
No active bleeding.
So, this is a case of penetrating gunshot wound over the right upper arm, potentially causing neurovascular damage. Looks like midshaft region of humerus could be injured, causing midshaft fracture. There could be injury to the brachial artery or radial nerve that wraps around the posterior midshaft in the spiral groove, which can cause wrist drop.
Can you tell me your pain on a scale of 1 to 10?
At least a 3.
And can you wiggle your fingers?
The left arm is intact and hence the movement of fingers would be normal here. We assess for movement of fingers to check the motor function of the major nerves supplying the hand, which could be stretched, compressed, or severed in case of gunshot injury.
The other hand?
Uh-oh.
Getting into even more detail specifically, thumbs up or wrist extension is used to assess the intactness of radial nerve. OK sign, meaning tip-to-tip pinch of thumb and index, or flexion of index finger can be used for median nerve, and for ulnar nerve, we can check for finger abduction or adduction, basically asking the patient to spread fingers apart and bring them together. The pattern of weakness tells us which nerve is damaged and thus where along the limb the injury likely is. If motor function is lost immediately after injury, nerve transection is more likely than swelling-related nerve injury. Besides motor function, we often also check sensation at key spots. Dorsal web space between thumb index for radial nerve, tip of index finger for median nerve, and tip of little finger for ulnar nerve. In this particular case, the movement of fingers is intact, meaning there is likely no nerve injury.
Well, it doesn't seem like you have broken bone, but we're going to put you on some IV antibiotics and some pain meds.
Got it.
Basic conservative management for this case do include pain meds and antibiotics like cefazolin for the open wound to prevent infection.
You, see who shot you?
Nah, I'm not even sure which direction the bullet came from. Hey, am I gonna lose any dexterity?
It's too soon to tell, but probably not.
There could still be swelling, which could compress the nerve and blood vessels later, which can cause limited hand movement, hence affecting dexterity.
I make balloon animals for a living. 2 birthday parties booked every Saturday, Sunday for the next year, so...
Wow, you must really love kids.
Not really.
Okay, you're gonna feel a little pinprick here.
Intraosseous access can be done in conscious patients, but it's very painful, so local anesthesia or analgesia is recommended if the patient is awake. 1 to 2 milliliters lidocaine, 1% without epinephrine is injected into the skin and periosteum before the drill.
It's just so we can give you antibiotics.
That hurt just as bad as when I got shot.
IO is very painful because of the pressure of the needle going through the bone periosteum that contains nerves in its outer fibrous layer that are highly sensitive to pain. It's especially painful when fluid is infused into the marrow cavity, which causes deep bone pain if not numbed. Awake patients rate IO infusion pain as worse than insertion pain. Without lidocaine, they may not tolerate ongoing infusions. So we provide 20 to 40 milligrams of preservative-free 2% lidocaine slowly into the intraosseous space, wait 1 to 2 minutes, then flush with saline before fluids or meds.
You put in an IL?
Yeah.
Don't worry, sir. There will be no more pain. Whitaker, team huddle. Join us, will you?
Oh my God.
Okay. Why'd you do that?
Dr. Robbie said everyone gets an IO.
if they are unconscious or unresponsive.
In unconscious or unresponsive patients, though, it's often done without anesthesia because getting rapid access is the priority and they won't feel it.
If the patient is awake and alert, it's just a standard IV, not an IO.
Stable yellow or green patients should definitely get a peripheral IV catheter and not an IO unless proper local anesthesia is given as described before, for the drill and before the infusion of fluids and meds.
Unless it's a mime. They can't scream.
Lidocaine for the clown.
We're at the door.
Is this ever gonna end?
Pardon? Coming through.
Blah, too much blood. Move that killer to the right a little bit.
Any better?
Not really. Radial pulse?
Still has it, maybe a little weaker. I can try and give you a bubble.
We discussed bubble intubation in the previous episode as well. Basically, if we perform a chest compression, we are essentially pushing air out of the lungs into the trachea and the glottis. If any fluid, secretion, or blood is present, like in this case, there would be air bubbles coming out of the glottis. We use those bubbles as a visual cue for where the glottis and vocal cords are, and then advance the endotracheal tube into where the bubbles are coming from. This is done if we can visualize the vocal cords, especially in situations like massive facial trauma, airway burns, or heavy bleeding where landmarks are either swollen or obscured.
Yeah, go for it. No, nothing. I'm not seeing anything. Okay. This bag, I want to prep the neck.
You don't have a bougie.
I have an 11 blade and a prayer.
Without a bougie, you could create a false passage on top of the trachea and kill him.
Chest compression is not yielding bubbles here due to massive hemorrhage, so we gotta perform cricothyrotomy via the scalpel finger bougie technique again. Here, a bougie is inserted after the incision into the trachea, and this helps guide the endotracheal tube into the trachea. Without a bougie to guide, inserting an endotracheal tube blindly would have a higher risk of misdirecting the tube into soft tissue, hence creating a false passage. That false passage can compress the trachea itself, preventing normal ventilation and causing death. Without a bougie, you could create a false passage on top of the trachea and kill him.
Craig?
Yep. No skin hooks, no bougie, old school.
We usually use the scalpel bougie tube technique because it's faster and safer, but if we have only a scalpel, we can still do an incision and insert the tube through the opening, though the margin for error is razor thin.
A tactical airway in my bag here.
What is that?
It's a control crite kit.
Oh, that's perfect. Use that on the battlefield.
A control crite kit is basically a pre-packaged surgical cricothyrotomy designed to make the procedure faster, cleaner, and safer, especially in an emergency.
Works in the pitch dark when you're under fire. I can do these with my eyes closed. Yeah, okay.
This is the handle with inbuilt scalpel blade, so there is no separate scalpel to grab. First, we palpate and stabilize the cricothyroid membrane and then make the incision with the built-in blade as we push in.
Knife leaves a trach hook behind, so you can't miss, right? Just good.
Now we advance the curved introducer into the trachea, which acts as both a guide and tissue spreader. Its curved shape right here helps avoid creating a false passage since it has to get lodged in the tracheal space.
Slide in the introducer.
We can feel the tracheal rings inside, hence he referred to it as a tactile airway. The introducer has a pre-mounted cuffed tube already loaded over it, so once the incision is made and the introducer is in the trachea, the tube is advanced in the same step. We slide the preloaded airway tube in, hold the tube in place, withdraw introducer completely, inflate the cuff, and ventilate with bag and mask.
Okay, feel the tracheal rings, good. Bob's your uncle.
The introducer has been removed. Now inflate the cuff and ventilate.
That was incredibly fast.
Balloon is up.
Why don't we stop these?
No room in the budget.
This is the ventilation via bag and mask. We can see the end-tidal CO2 colorimetry right here. The purple color indicates there's no exhaled CO2. If it changes to yellow, this means there's exhaled CO2 present. The color change has been shown to yellow, which means there is exhaled CO2, which means the tube is in the trachea in its correct place.
Yellow and end tidal.
It's okay now.
Yeah.
Thank you, Dr. Abbott.
Okay, let's pack the oral cavity with Acrylics and see how fast the head and neck can take him up to the OR. Great job, everybody.
This is what emergency medicine's all about. We save the patient from imminent life-threatening danger and stabilize the patient enough to buy additional time for the more definitive treatment, which in this case is surgical exploration of the head and neck to control the bleeding and repair wounds due to the bullet.
What else you got in your go bag?
Oh, just wait and see.
It's important to convey information about the patient's state, whether alive and well or in critical state or dead, to the family members so that they won't have to stay in oblivion for long. Most of the times, the fear of the unknown engulfs you more than the knowledge of bad news.
Javadi, this is Sally. What does she need? A gunshot wound to the back of T11. Good pulse, but probable spinal cord injury.
At T11, the spinal cord's lower portion is injured since spinal cord ends at L1 or L2. So the segments affected will actually be at the lumbar level and below, so lumbar and sacral segments. The injury here causes lower motor neuron signs at the level and upper motor neuron signs below. The possible spinal cord injury here could cause paraplegia along with bladder and bowel dysfunction. The fractured T11 vertebra could cause instability with risk of cord compression.
Can you move your legs?
I'm trying. Am I paralyzed?
There's some hope for recovery.
The lumbar and sacral segments, which would be affected by the T11 injury, carry the motor and sensory pathways to both lower limbs and pelvic organs. A bullet disrupting these segments or the blood supply to them will interrupt all descending motor pathways, hence paralysis below that point, meaning paralysis of both lower limbs, which is called paraplegia, along with bladder and bowel dysfunction. There would likely be a partial transection of the cord or rarely a complete transection. This would cause spastic paralysis of the muscles supplied by the nerves emerging below the affected level due to the injury to the upper motor neurons traversing downwards from that level, and flaccid paralysis right at the affected level due to the injury to the lower motor neurons emerging from that level only.
Keep her on the backboard and monitor for intra-abdominal hemorrhage, and neuro ICU will triage to CT, okay?
Besides the spinal cord injury, other injuries due to the bullet traversing forward could happen. There could be retroperitoneal bleed from kidney or vessel injury, intraperitoneal bleeds, and abdominal organ injury as bullet traverses the abdomen from behind. Hemothorax or pneumothorax is also possible if rib or pleura are involved. Hence, it would make sense to monitor for any hemorrhage and do a complete CT scan for all these once the patient would be admitted to neuro ICU for the spinal injury.
Sally, pinprick right here, okay?
Walsh knows about the case. They're holding an OR. And the hits keep coming. Let's go.
What do you have?
Semi-conscious, only responds to pain. Decent karate. Strip him.
Left upper quadrant entry.
A left upper quadrant entry point for a gunshot could injure organs like the fundus or body of stomach, spleen with splenic artery and vein, splenic flexure of colon, tail of pancreas, and upper pole of left kidney, among others.
Grab his foot!
Whoa, gun! Gun! He's going for his gun.
All right.
Stay down! Stay down!
So the patient here is unresponsive to verbal commands and only responds to pain. So he doesn't quite know what's happening and just felt attacked and went for his gun, I guess.
SIG P365 9mm. Driver's license? He just got here.
Not responding to pain now?
The ongoing hemorrhagic shock from the bleeding inside likely led to loss of consciousness here.
All clear.
You sure?
He's unconscious. Everybody back to work.
Agonal breathing, he needs an airway.
Agonal breathing means the patient is in severe respiratory failure or cardiac arrest. It's not effective breathing at all, just brainstem-mediated gasps, which is treated as equivalent to no breathing or apnea. The patient is in peri-arrest or in arrest. If there's no pulse, we start CPR. If pulse is present but there is ineffective respiration, we provide bag valve mask ventilation immediately. For securing the airway, we gotta intubate the patient. If not, we should opt for a surgical airway in cricothyrotomy.
Working on an IO. Drawing up ketamine and sucks.
Since the patient is unconscious, we can opt for an intraosseous access here. We know ketamine and succinylcholine are used for procedural sedation. Succinylcholine here instead of rocuronium because it has a shorter onset of action and shorter duration of action, making it perfect for a quick sedation as well as short-term sedation because it easily wears off in case the intubation attempt fails, so that the patient can regain muscle tone quickly, allowing spontaneous breathing if they still have a pulse.
Yeah, have at it. Concealed carry permit. We'll run his ID. These wounds are too big for a 9.
Failed IO. Guy's huge. Needle won't reach the bone.
If the IO failed because the patient's soft tissue is too thick for the standard needle to reach bone, it means the needle is too short for the patient. Standard adult IO needles are 25 millimeters, which are blue. For bariatric or very muscular patients, we need the 45 millimeters yellow needle to bypass excess tissue. If not, we try another IO site with less soft tissue besides the proximal humerus, like proximal tibia, distal femur, or sternum. Or we go for rapid peripheral access with large bore peripheral IV. IV in AC fossa or central access with a central line.
He needs induction meds and blood.
I'm having the same problem here. I don't see anything usable for an IV.
Robbie, what? Guy needs access, but the IO won't reach the humerus. Proximal tibia? Yes? Yeah.
Talking about different IO sites here. In adults, first we try proximal humerus. If not possible, then we try for proximal tibia, distal femur, sternum, and distal tibia. Proximal humerus is preferred because it's the closest to central circulation, and hence there is fast delivery of fluids and meds. It provides good flow rates of up to 5 liters per hour with pressure, and is inserted in the greater tubercle. Proximal tibia is also another site for IO, which is easy to find. It's inserted in the medial surface of tibia, just below the tibial tuberosity. It provides a slower flow compared to humerus with around 1 liter per hour with pressure.
Tibia is not great access. You can only get a liter an hour down there.
You get what you get.
If not tibia, we have to even go for distal femur, sternum, or distal tibia. So whatever saves the life of a patient is going to be done.
God damn it!
Whatever that is, can you please turn it off? I can't hear myself think.
Stable for the ICU. Get her up. I'll be right.
Copy that.
There are quite few reasons an ankle monitor, the electronic monitoring device put on her leg, would beep like this. Common ones include tamper alert, where if someone tries to remove, cut, damage, or excessively tamper with the strap or device, it will detect this and emit a loud persistent beep. This is an immediate alert to both the wearer and the monitoring center that tampering is occurring. Or there could be inclusion or exclusion zone violation, where the device beeps while entering a forbidden area that is exclusion zone or leaving an allowed area that is inclusion zone.
I already have one. Keep that away from me.
It's not for you.
First of all, even though the device might be malfunctioning and just beeping when it shouldn't, she shouldn't be tampering with the device. She would be in further trouble due to this. Second, that's a waste of an IO needle right there in MCI situations where the IO needles could have shortage soon.
Show's over.
Are you gonna get in trouble for that?
Probably.
What's going on out there?
A lot of people were hurt at the festival.
Just wanted to add that children who've experienced or seen mass shooting or seen casualties dying in front of them are more likely to suffer from depression and PTSD as they grow up, which could affect their academics, worldview, and also give rise to substance abuse in adulthood.
I need to use the bathroom.
I told him to use the sink.
What is wrong with you?
Would you rather I take him out there?
Hang on, I'll be right back, okay? Here.
Urinal is frequently used in patients with limited mobility like fractures, post-op, weakness, or paralysis who can't get out of bed. It prevents falls in elderly or post-surgical patients by avoiding unnecessary trips to the bathroom. It's also useful to monitor urine output in critically ill patients.
What's that?
It's a urinal. You pee in it.
I think I'll just hold it in.
Pull out. I found a 4-blade.
It's better. Shit. I lost the light. The battery must be dead.
This one's dead too. Anybody have a laryngoscope with a light that still works?
The light is typically provided by a bulb located within the blade of the laryngoscope. It turns on when the blade is fit with the handle to help us visualize the airway and vocal cords for intubation. The batteries running out in the laryngoscopes is a disaster, especially if we are in the process of intubating the patient and have already given muscle relaxants to relax the airway.
We will check. Check quick. This guy's paralytics are wearing off.
There are two sides of this. One is that we gotta intubate before the effect of muscle relaxant wears off, otherwise we can't intubate. We're using succinylcholine. Its duration of action is just 5 to 10 minutes. The other side of this is, suppose we didn't get a laryngoscope to work and illuminate the airway. Since its duration of action isn't that long, it will wear off immediately and the patient can spontaneously breathe again. Till then, we can provide bag mask ventilation. If it was rocuronium here, its duration is 30 to 60 minutes, so it would take a long time to wear off until the patient can breathe again, unless of course reversal agents like neostigmine are used. So Sux is appropriate for these emergency scenarios.
Keep bag and give me a 7-0 ET tube.
He's a big guy. He needs an 8.
Not for this. Number 7. What are you doing?
Tactile intubation.
Tactile intubation is essentially a blind intubation technique guided by touch instead of sight, usually done when there's complete darkness, such as field combat medicine or when you don't have a working laryngoscope like this case. First, we use an oropharyngeal airway or digital sweep to clear the mouth of secretions. Then, with our non-dominant hand in the mouth, we palpate the tongue, then advance until we feel the epiglottis with our fingertip. This is easier in children because their airway structures are smaller and more palpable. Now we hold the endotracheal tube in our dominant hand and slide it alongside the palpating fingertip, directly in between the vocal cords. We gotta confirm placement by listening for breath sounds, feel for air movement, and use end-tidal CO2 to make sure the tube is in its correct place in the trachea and not the esophagus.
My index finger goes in the vallecula, and my middle finger will guide the tube past the epiglottis.
This is a variation of tactile intubation where we use 2 fingers instead of just 1 to guide the tube. We insert the index finger in the vallecula, which is the groove between the base of the tongue and the epiglottis. Placing our finger here lets us lift the epiglottis slightly, just like a laryngoscope tip would. Then the middle finger is used as a track or guide for the tube tip to pass into the trachea. The tube is advanced alongside the middle finger until it's in the airway. The index finger stabilizes and opens the view space, while the middle finger acts like a manual introducer.
But if you hit the esophagus, he's toast. You told us never to pass the tube unless we see the vocal cords.
Correct. Not today. If I stay in the midline, I should be able to get it past the cords.
Definitely, blind attempts increase the risk of esophageal intubation. If the tube goes into esophagus, there will be no oxygenation to the trachea, and the patient will die of respiratory arrest and hypoxia since the patient is sedated and also can't produce spontaneous breathing efforts. But here, this is a last-ditch, no equipment, can't see anything situation. The patient is agonal and will die without an airway right now. There's no light in the laryngoscope, and they're relying on tactile confirmation, feeling the vallecula, epiglottis, and glottis as the only possible method. So, the risk here is accepted. It's better to try and possibly miss than do nothing and guarantee death.
Balloon up. Bag him.
Looks good on the end tidal.
Means the exhaled air has CO2, which means the tube is in the right place.
Slick move, boss.
No pulse. Start compressions.
Okay, get him up. Try to get him back with 2 liters. That is as much as we can afford per patient.
She's not pumping the bag here. If you don't pump the bag, there is no positive pressure generated, so the air will not be pushed into the lungs. You either have to pump the bag or let the ventilator push air into the lungs.
Leg is too slow. Upper arm is 5 times as fast.
The best that we can do. Keep at it. We'll get him back.
Robbie, you need help here.
The patient here has likely suffered from severe hemorrhagic shock, leading to no pulse being palpable.
Langdon?
Keep squeezing.
As said before, the proximal tibia is being used as the intraosseous access site here, since proximal humerus, which is the best site, couldn't be accessed. So we had to settle for the slower flow site in proximal tibial with only 1 liter per hour max.
How are you making out?
Lots of emails and photos coming in from concerned families.
It'll be easier once they've entered every patient's MCI number.
Here we go. Looks familiar?
The tatted guy who died and was in the morgue.
MCI 7. His name is Vincent Rivera.
He must have had friends or family in the cafeteria who sent in the photo.
I'll text them we're coming.
Delivering bad news is an intense and difficult job.
What are you doing?
Giving this guy a chance. He needs a big central line for a fast transfusion.
You can't do an IJ without an ultrasound, especially on a guy this big.
You'll kill him if you collapse so long or hit the carotid.
A large bore central venous catheter in a major vein, though takes longer time to set up, does have faster infusion rates than the intraosseous infusion, which is faster to set up. Central lines can be put in a major vein like the internal jugular, subclavian, or femoral. Here, the internal jugular line can technically be placed using landmarks only, which is the traditional method, but in a large patient or in emergencies, ultrasound guidance is now considered the standard of care. In obese or muscular patients, neck anatomy is harder to feel, hence the carotid and IJ positions may be shifted or deeper. Without ultrasound, there is higher chance of puncturing the carotid artery, causing massive hemorrhage. If the needle is angled too low or lateral toward the lung apex, it could puncture the lung tissue and cause pneumothorax. So in a mass casualty event like this, when ultrasound may be scarcely used, if the patient is critically unstable, we can actually do a femoral line because femoral vein can be landmarked more safely.
I'm not doing an IJ. I'll hook that bloodline, bring it up here. This is a supraclavicular
Subclavian.
So, it's gonna be a supraclavicular subclavian central line. Subclavian access is also often preferred in such emergency cases because it's fast, can be landmarked without ultrasound, and is away from the airway or neck region. Supraclavicular approach as opposed to infraclavicular gives a more direct and straight path to the superior vena cava, often with a straighter trajectory and fewer needle redirections, along with less risks of catheter kinking. It's easier in obese patients too because there is less soft tissue depth compared to the infraclavicular site. And yes, it can also be done without ultrasound because of its consistent landmarks. However, there is still a pneumothorax risk as we're working right over the lung apex, or risk of an accidental subclavian arterial puncture. And it's not ideal if the patient has clavicle or upper rib fractures.